Hi guys, we're going to talk about chapter 36, and this is going to look at pain management in our pediatric population, and I'm just going to get started here. So when we think about pain, it is very highly individualized and very subjective. If a person complains of pain, we have to take it as it is. I will be quite honest with you, when you have pediatric population, you have that teenage population, right, who has their phones, their iPads, all of their electronics, and they're playing on them. And when you ask them if they have any discomfort and they tell you a 10, it's going to be hard to believe, right? But their pain is subjective. And so if they're experiencing a pain of 10, we have to believe them. It's very individualized, and we have to believe what they're saying. The American Pain Society has labeled pain as really that fifth vital sign because it really needs to be assessed when all of the other vital signs are taken. If we leave pain unmanaged, it could definitely lead to serious physical and emotional consequences. So making sure we ask every time we're in there for vital signs to rate their pain level. And we'll talk about the different scales as we move through this slideshow. So classifications of pain can be duration, etiology, source, or location. When we think about duration, is it acute or is it chronic? When we think about etiology, is it nociceptive or neuropathic? Where is it stemming from? And then source and location, is it somatic or visceral? And we'll talk a little bit about each of those as well. So let's look at each of these. So acute pain, so we're looking at duration, right? Acute or chronic. Acute is that rapid onset. It's going to vary in intensity. It may last for a few days, like a trauma, maybe an invasive procedure. Maybe we have a little sore throat. That's going to be that acute pain. If we're talking about chronic pain, that's going to continue past the expected point of healing. It can be continuous, it could be intermittent. It may really impair a person's ability to function. So some of the examples for that would be abdominal pain, very nonspecific headache, or even chest pain that could go past the point of the expectation of that healing. Nociceptive pain or neuropathic pain are the other two etiology classifications. Nociceptive is due to some type of noxious stimuli. So it's pain that's perceived that correlates with the degree of intensity. Nervous system function is usually intact. So we're talking about chemical burns, sunburns, cuts, bladder distension, right? It's that noxious stimuli that's reflecting that pain. When we think about neuropathic pain, that's a malfunction of our peripheral or central nervous system. So they may describe things like, oh, it's a burning sensation, it feels tingling, it's shooting, spasm-like, right? Then we're thinking neuropathic. So pain after a spinal cord injury, maybe they have phantom pain after they've had an amputation. So just understand the differences in our duration, which is acute or chronic, and etiology, which is nociceptive or neuropathic. Source or location could be somatic or visceral. Somatic develops in the tissues, and visceral develops within an organ. So when we're talking about tissue pain, it could be superficial, it could be deep. Remembering that superficial is kind of that on the surface. Prickly, burning sensation. Deep is going to be more inside of that tissue, like in your muscles and your tendons and your joints. Visceral pain, again, develops within an organ. So distension of an organ, maybe they have hepatomegaly, they have splenomegaly, right? It's that distension of those organs that's creating that discomfort or that pain. Contractions, ischemia, organ spasms are all visceral pain. So we've got really 6 different types of pain, right? Duration, acute, chronic, etiology, nociceptive or neuropathic, and then source location, somatic or visceral. So factors that can influence pain will include age and gender. Pain can really start in our preterm newborns. Cognitive level is also a factor that is influencing our pain. As our cognition increases, our understanding of pain and impact of pain also increases. Temperament interventions may differ based on a child's temperament. So if they're easygoing, we're going to probably intervene a little bit different than our more aggressive temperament that a child may have. Any previous pain experience can definitely be an influencing factor. How many episodes of pain have they had previously? What's the type of pain? Have they had any effectiveness with any treatments that are going to affect the perception and response to pain? And then definitely family and cultural backgrounds can also influence our pain factors. So response to pain is highly variable in our infants. We can have behavioral or physiological changes, right? The infant's not going to be able to tell you that they are in pain, that they're uncomfortable. So we really have to observe our infants to see what's going on that might indicate that they're in some type of discomfort. So behavioral wise, they're going to have facial expression changes. Their body movements are going to be changing, right? If they're pulling their legs up to their belly, that might indicate some belly pain. They may be crying excessively, like we've changed their diaper, we've fed them, we've done everything we could do and they're still crying. That would indicate that there may be some pain behind that crying. Physiological changes, right? We're going to have an increase in heart rate, respiratory rate, blood pressure changes, oxygenation, vagal tone, palmar, sweating. All of those would be physiological changes, right? We can put a number to it. We can actually see it. So those would be our physiological changes. So remembering infants can't tell you, so observe them and see what's going on that might indicate pain. When we use age-appropriate language to assess pain in older children, we want to make sure that we're using understandable words for toddlers, such as owie, right? Do you have an owie? Do you have a boo-boo? We want to encourage our toddler to verbalize that pain. 2 to 4-year-olds can express the presence of pain. 5-year-olds can typically describe the pain. Preschoolers may need to be coaxed to discuss their pain as they feel it's something to be expected. So they may try to escape, right? They may try to run out of the room into the bathroom, or in the hospital to go to the bathroom, to the playroom, because they're trying to not talk about their pain, right? Preschoolers are magical thinkers. They may believe that this pain is a punishment for misbehaving, or maybe having any bad thoughts. So making sure that we're coaxing them, like making them think like it's okay that you're uncomfortable, it's okay that you have pain, we just need to talk about where it's located. Some of the pain scales that we can use for our preschoolers are our FACES scales. Maybe they can put a little drawing, right? 4 or 5-year-olds can draw and then point to pain on their drawings. They could even point to their bodies and let you know. School-age children can usually report type, location, and severity because they're well developed with their language skills at that point. And then, of course, our teenagers or adolescents usually are more concerned about their body image and fear of losing control. So a lot of times they're going to deny pain, they're going to refuse medications because they don't want to lose that control. So why do we use pain scales? This really just allows for consistent reporting. Pain is quantified, and it really helps to align a nurse's assessment with what's being reported. If we use different pain scales, it's not going to be consistent. So if we're asking about pain, we need to make sure we know from the previous nurse which pain scale did you use so it can be consistent. The FACES scale that you see there is typically used for our 3-year-olds and up. And you can just see like the smiley face, nothing hurts, to the really worst pain ever, right? The patient's really crying, they have tears. So you can show the 3-year-old, how does your pain make you feel, right? And have them point to one of those faces. All of you should be familiar with the visual analog scale, right? That's that number scale. Usually 8 and up can use this. Can you rate your pain from 0 to 10? 0 being no pain, 10 being the worst possible pain you've ever experienced, and then they can give you a number in between there. As far as adolescents, 8 to 17-year-olds, you could use this picture drawing, right? They can point on the picture to where their pain is actually located. So this is the FLACC scale, and you can see FLACC stands for face, legs, activity, cry, and consolability. You can see the scoring is 0, 1, or 2, meaning the highest score is 10 and the lowest score is 0. So if you're thinking about even your visual analog, right? 0 to 10, 0 no pain, 10 being the worst pain ever. This is just going to give this to you as you observe your behaviors of your patient. So if your patient's face really is just kind of a normal face, no particular expression or smile, that's indicating pain, then you would give it a 0. If their legs seem to be tense, pulled up, jerking, right, then we might give them a 2. As far as activity, right, you just can go across and figure out what your patient's behavior looks like. The other caveat to that is, remember most, I would say 3, 4, 5-year-olds, right, sometimes don't care for the nursing staff or medical staff. So make sure that you're observing your patient maybe from the window if they are staff anxious, so that you can get a really good indicator of pain. Don't put them in pain because they're staff anxious. Put them in pain because they really have pain. So when we think about pain management in children, remember individualized interventions are based on the amount of pain, what's the developmental level, what is their temperament, have they had any previous pain experience, do they have any coping strategies for their pain. Some non-pharmacological interventions can be utilized, as well as some pharmacological interventions. So when we think about non-pharmacological, right, that's relaxation, distraction, guided imagery, versus pharmacological, which we're all used to, right, is just giving medicine to help with the pain. We do want to make sure we're educating our child and family about pain relief. So let's think about techniques for pain management. We've already talked about there's non-pharmacological interventions and pharmacological interventions. So the non-pharmacologic interventions, right, might be relaxation, seeing if they can do some deep breathing exercises. Maybe we just do some distraction, right? If we're placing an IV in a patient, that's gonna probably have some discomfort or pain with it. So maybe we play music, maybe we have an iPad in front of them. We're just distracting them from the discomfort they may be experiencing. Pharmacological, right, our analgesics, Tylenol, ibuprofen, maybe our PCAs that have our bigger narcotics. Local analgesias, to me, that would be like our J-tips. If we're placing an IV, right, we can put a J-tip, which is just a shot of lidocaine that just goes right under the surface of the skin, right? It's just a local analgesic to help with discomfort of placing that IV. Again, here's some more non-pharmacological techniques. It's really important to place some non-pharmacological techniques in place for your child, right? They may have breakthrough pain where we can't give meds. So teaching them some things that they can do to try to get through some of that discomfort. You can see again, relaxation, distraction, thought stopping, positive self-talk, right? Biophysical strategies. For our infants, we can do some sucrose, sucking, right? That sucking is just an automatic reflex that will help with any pain. The sucrose just helps again with that. Heat and cold application, massage, pressure, all of those would be non-pharmacological interventions that we could utilize. Pharmacological factors, just make sure you're aware of what drug is being used. If it's for mild to moderate pain, right, we're going to use a non-opioid analgesic, Tylenol, ibuprofen, maybe some other type of NSAID. If it's more moderate to severe, then we're thinking about our opioid analgesics. We can do some adjuvant drugs, meaning we can put these in along with some of the other analgesics to kind of help with some of that anxiety relief, because right, if you're in a lot of discomfort, you get a little anxious about it as well. Making sure we're checking the child's status after we give the medication, right? There's no sense in doing an intervention if we're not going to follow up with it. So if we do an intervention with some pharmacological meds, make sure we check the child afterward to see if it helped. Make sure we're also assessing what's the type of pain, right? We've talked about those. What's the intensity? Where's the location of the pain? And are there any factors that are also influencing that child's pain? Preferred routes of administering medications. Oral is the simplest way. Just remember, oral is a little bit slower acting. It's faster acting than some other medications, but don't expect to give Tylenol and then 15 minutes later they're healed, right? It's going to take a little bit longer for that. The rectal method we don't use a lot. Seizure medications can go rectally. Their absorption rates are really vary, so we just don't know. But if they're unable to take oral medications, let's say they're vomiting and now they have fever, right? We don't want to give Tylenol orally because they're going to vomit it up, so we may have to give rectal Tylenol. IV, severe pain, emergency situation, PCAs, right? They can control that. Topical meds can help with pain with procedures. Local nerve block, probably won't see a lot of that, but those are available as well. So what's the nurse's role in pharmacological pain management? Make sure you're doing your 5 rights before you give that medication. Make sure you know how that medication is going to work in that patient. It's crucial to assess level of consciousness, especially if we're giving opioid type medications, right? We want to make sure we get vital signs beforehand. What's their oxygen saturation level? Sometimes these medications can change urine output, any adverse effects, right? Respiratory depression with our opioids. So we want to just make sure we're really getting a good baseline assessment before we give any pharmacological interventions. Checking the emotional status, making sure the parents are aware of the medication they're being given, and are there any teaching points that we need to give. So some common adverse events associated with opioids, this should be familiar for you, right? If they're having an interaction to the opioid medication, constipation's a huge one. Pruritus is a big one, and then nausea and vomiting are also some common ones. And that concludes chapter 36 on pain. I've tried to condense it as much as I can, guys. Make sure you listen to it carefully, and if you have any questions, we can talk about it in class, or you can shoot me an email. Thanks, guys.